Thank you so much. I'm excited to be here today and learn with you today, and hopefully I can share something that will be valuable to you. In addition to being a part of Health Catalyst and working across many different clients in the United States and some international clients in population health and value-based care, I also worked at Intermountain Healthcare for about 27 years and was fortunate to have a payer, a physician division, and hospital systems to be able to understand how to do this work even better. So hopefully be something that will great and learn, and I look forward to learning from you today. So I want to just start by level setting. And I know that some of you could talk about this day in out, but I know there might be some people that value-based care is new to. Value-based care is really tied to positive outcomes, where fee-for-service is tied to the amount of care that is provided. So this shift is pretty significant as you think about it, because, again, we talked it's based on quality rather than quantity. And because of that, coordination of care becomes really important. And ensuring that the right care is at the right time, in the right place, and actually provided by the right provider is key. And it starts to shift to focus on health and prevention rather than managing by each time you go into the hospital or each time you go into the clinic. And because of this idea of focusing on quality, you get to start to focus on health and prevention rather than just on disease. And it is imperative to manage chronic conditions, as we talked about. And of course, the end aim here is to achieve the triple aim, which is better care for individuals, better health for populations, and lower cost of care. And of course, that is the value equation that we always talk about. So just who benefits from this? If we do this right, we really all should benefit. As patients, we should benefit from having lower costs. And when I talk about lower cost, it's really out-of-pocket cost, getting better efficiency and sharing that back with patients. And of course, most importantly, is better outcomes. As a provider, most providers, clinicians have joined being in healthcare because they want to help people. And this higher satisfaction from patients and individuals that are participating in value-based care and the better care efficiencies and outcomes really increases engagement for providers. And it really allows the providers to do something that they've wanted to do ever since day one in being their career. From a payer perspective, it's stronger cost controls and reduced risk, because actually the individuals that are making decisions about care are really closer to the front lines and really we're providing care. And from a supplier perspective, it's the first time we've ever been able to align prices with patient outcomes. And of course, we talked about society reducing overall healthcare spending and overall better health. So I'm going to start with, again, I'm sharing a lot of the experience from the United States as we think about it. And we see four main segments interacting regularly with population health. And I just want to review these quickly. One is the healthcare system, or the IDN, which is the Integrated Delivery Network. These are groups of hospitals, and some of these groups of hospitals actually have ambulatory care, long-term care in them, or could even have physicians that are employed, but not all of them usually have all physicians that need to be involved in value-based care. And they participate in a variety of risk arrangements, and I'll share with that a little bit later. Excuse me. From a payer perspective, there are multiple payers, and they have multiple risk arrangements with multiple product offerings. And then we have the third category, which is our accountable care organizations, or our clinically integrated networks. That's what ACO and CIN stands for. This was really put together to have regulatory structures that allows providers to work together to provide value-based care. So for instance, many systems in the United States don't have everything that you need to manage the entire chronic care condition. Like they might not have long-term care, or they might not even have primary care. So it's been a regulatory structure so that they can share information related to improving the health of individuals and patients. And finally, the last is ambulatory delivery. This is really, ambulatory delivery is the outpatient setting, mostly primary care doctors who are actually participating in health system or the ACN or CIN that are actually providing services so that these organizations can provide the best care. And as you know, one of the things you're going to see and hear over and over again, primary care is incredibly important as we think about value-based care. So if you think about those 4 segments, regardless of what kind of system you're in, over and over these groups, you'll see them asking the question, how do we succeed in this value-based care component or environment? And over time, they start to involve that they actually need a data-informed, scaled infrastructure, because each of those entities has population-specific delivery that they need to provide. They understand their outcomes and their total cost and engagement. Each of them has quality goals, cost goals, and revenue goals. And I wanted to identify revenue because I think about revenue in the way that you have no margin, you have no mission. And when you're taking value-based care, you actually have more accountability on the financial side to lower the cost of care. So what we've seen is actually individuals, groups of these pulling together and putting a coordinated plan and thinking about a scaled infrastructure around data particularly. So I want to spend just a couple minutes. This is serving our operational needs. And these are those infrastructure that are aligned and things that you'll see that no matter what segment you need to do. In the darker blue, it is the primary need in these 5 areas. In the lighter blue, it is a need, but maybe not primary due to their role in value-based care. And across the top, you see the healthcare system, the payer. I've separated ACO and CIN because they're slightly different, and ambulatory delivery. And you can see each one of these organizations need very similar things to operationalize value-based care. And I'd like to highlight in particularly the use of a data infrastructure. They need to bring the right data together to perform their roles. And the second line is building, maintaining, developing, and delivering analytic intelligence to end users. And I'm sure that most of us understand that, but it's a very difficult process as you think about how do we do that. Just highlighting again, you need to coordinate delivery across employed or non-employed providers here. You need to understand how to provide data to manage populations that are clinical and care management services. And even at the bottom, how do we bring the consumer or patients into the data and understanding how we achieve value-based care? Now, this is a really busy slide. I just want to highlight a couple things. One is on the y-axis, we have the level of financial risk. On the x-axis, we have the degree of care coordination, provider integration, and accountability. As we've seen the progression, as you take more risk and increase the value equation, you actually have to increase your financial risk and you have to increase your degree of care coordination, provider integration, and accountability. And here in the US, there is no way that we could have gone from fee-for-service all the way to capitation without some practice. So what you'll see in here are kind of 4 bundles of progression that I'm going to talk briefly about. One is fee-for-service, which we still have in the United States, but we are moving more towards value-based care. But as we talked about before, this is really aligned to being incentivizing visits and getting paid for everything you do. In the next bucket, the next 2 are primary care initiatives that have happened. The first one is primary care initiatives around additional monies given to primary care to actually manage services. And it creates more proactive patient care alignment. The next one is performance-based contracts. And this is actually not only adding in the monies given to primary care to do a better job and support some of the important management, but it actually starts to measure the outcomes and improvements that these primary care groups have done. So if they achieve a certain performance, they actually get more monies to actually continue to manage these populations. So you can see it actually really supports the idea of improving quality, performance improvement progression over and over again in these models. The third bucket is really condition or service line models that we've seen. So in addition to primary care, we actually added bringing in the specialist and being part of risk contracts with a specialist. And it creates incentives alignment for unique services, such as managing diabetes with certain type of specialists, which you need, or cardiology, which you need in there. So we started to bring in more than primary care. In the last 3, this is really where we get more to value-based care. The first one is shared savings. This is where is you manage what you have. As you have some accountability for the medical spend. And if you achieve that and quality indicators, then what we call is you get upside, which means you get some incentive payment or you get shared back those savings as an organization. In the next one, shared risk, actually, you still have shared savings. So if you do positive, you'll get shared savings back to the organization, which you can put back into the money to plan and improve care. But you also have what we call downside risk, which is actually if you don't achieve those goals, that actually you get some penalties for not achieving, and you have actually a loss. So you have a plus and a loss. Finally, in capitation, this is the greatest financial and operational accountability, looking at total cost of care. And you're looking at the total management of the patient, both the primary care and as well as a specialty care, inpatient setting, exactly all of that care. And so I'm going to spend a little bit of time today talking about capitation. This is something that we're seeing more and more in the United States. So, as we talk about the major tranches that we've been through, in 2012, we started what we called Pioneer Accountable Care Organizations. It mostly had upside risk, and it had those two organizations around primary care. As we moved to 2016 and we learned more, we started to ask, increasing that risk, and we started increasing the specialty shared saving risk, and we talked about, and today we're spending more time in direct contracting in 2021. Including our health plans and other entities, as well as focusing on contracting as an avenue to generate the ability to manage these individuals. So CMS, for those who maybe many are aware what CMS is, but CMS is our national payment, and they've actually created these capitated models. And I'm going to talk a little bit about some commercial models that have happened too. But right now we're focusing on 3 capitation models that are available. One is looking at professional primary care capitation, where it's not 100% capitation, it's 50% savings and losses. And then it moves into global capitation, which is 100%. So we're looking at that with primary care particularly. And then global total care capitation actually brings in the specialty. So even within capitation, we have some different models. I'm not going to spend a lot of time on the right side of the slide, but this is really talking about the types of patients that are in these models. In the United States, we primarily have Medicare beneficiaries. These are people who are over 65 or have disability that are covered by our national. And then we have those that have high needs that actually are qualified to go into a long-term care facility. So their needs are very high. And then we have the dual coverage Medicaid, which is the state coverage with some national perspective, and Medicare. So these are really our national insured groups that are in part of these contracting models. So I wanted to share with you a couple examples. One is called Concerto Health, and there's many models that you can look at. Concerto Health is really interesting. It's a pretty new organization, and they actually provide comprehensive in-home care to seniors. And they offer an all-inclusive, as you can see, care to seniors in value-based models. So in Medicare, Medicaid that you saw earlier. And how do they do this? They actually have a combination of telehealth. They use a lot of telehealth, and they have in-person care delivery, because they know that they're looking at seniors who want to stay home, and they want to provide all the services in the home. They also have brought in their own EHR. So they have the electronic health data that they bring in. They have assessments where they're looking at unmet social needs and bringing this in from a data perspective. They manage their care plans and quality improvement opportunities, understanding those gaps. And below is really kind of some models they've done. The first model, actually, they don't take the patient out of the value-based program or existing processor in there, and they can keep their PCP or the primary care physician, but they actually augment. So that wouldn't be taking a comprehensive risk. But in the next model they do, where it's a geriatric primary care model, which they become the primary care. And through that, they're offering telehealth and inpatient care delivery. And they also provide in-home primary care, and they orchestrate the services needed to maintain the physical and emotional health. And so they have social workers, care managers, dietitians, physical therapists. They'll bring in all those, and they're taking risk in managing all of those and coordinating through the electronic medical record and the reports that they have. And finally, the last program they have is the most intensive program. We have a program called the PACE that's happened about 50 years ago. And it's really been a program where we try to maintain very at-risk seniors, and particularly at home. And it's been a program that we've covered it for many years, but it's become very popular in the last little bit. So it's more intense services. But at the end, they also have a brick and mortar PACE center just in case someone needs to go in respite or they can't maintain them at home. So you can see they've taken the whole thing. And I think what's interesting here is that 50% of, they've decreased admissions by 50% and readmissions by 50%, and ED visits by about 15%. So you can say by saving that money on the upside, they're actually able to invest more in the community and primary care model. Another alternative payment model in the capitated primary care is a concierge model. We're hearing a lot about this. Patients really have direct access to the physicians. In fact, many of these organizations give them their cell phone numbers. And you can see the ratio of patients to physicians is less than in many other programs that have happened. But again, we're seeing a result of 15 to 30% decrease in their hospitalizations. Of course, that is the focus, that area. And right now, we have another model that we're seeing emerge as a primary care employer model. So this is not to our national, this is really to our employers, where our employers are actually given an option for their employees to participate in this program. And it's a fully capitated program. It's 10% cheaper for the employer and 10% cheaper for the employee. And they actually work together and have the employees have a shared savings model. So they actually get some benefit back financially if, as a group, they've improved their utilization and improved their care. And right now we're looking at about 5-to-1 ROI on that. So that's a very interesting program to watch. Another concept is I wanted to share like some of the large payers. We have a lot of payers, but United Healthcare in particular is really focused on value-based care and looking at capitation. Right now, they cover about 15 million patients through their value-based care. They have 55,000 primary care individuals, and they're including and increasing that 10,000 per year. So overall, when you start to look at places like Concerto Health and United Healthcare, they actually have about over a third of all of our primary care that are in value-based and these capitated models. So we see this moving pretty quickly and becoming very popular. The other group I want to share is Blue Cross Blue Shield. They cover over $62 million lives and members through value-based plans. And so we're seeing this grow. We think it's here. We don't think it's going to change. But it has been, even through COVID, we've actually seen faster growth in value-based care than we've seen in the past. So just wanted to talk a little bit about the framework as we think about how do we go about thinking about value-based care and how do we get to where we need to be in population health. This is a really simple framework. It has a lot of detail behind it. But the first thing is we think about data and analytics as data transformation, laying the groundwork for a high-functioning analytic platform and bringing that data together. 2, that we start to look at analytic transformation, build a structure so we can understand gaps and evaluate our opportunities. And 3 and 4, 3A and 3B are actually financial transformation. As I mentioned before, you need to balance your risk to sustain a course forward so that you have money that you can actually provide that care. And of course, we all know about care transformation, identifying and implementing those appropriate changes to lead to what we would call the triple aim, as we talked about earlier. So population health has many factors. It requires collaboration with leaders in healthcare, but also politics, charity, education, business, and many others. On the right-hand side of the slide, you'll see that there is a lot of data that is involved in quality of life. or improving health outcomes, from policy of physical environment, air, and water. As we think about socioeconomic factors, important income, education. And I would like to highlight that clinical care is very important, but it's really only about 20% of what we look with the data, which would focus on access of care and quality of care. And we know today, particularly from COVID, that health behaviors is really an important aspect to think about what data we should bring in. This is a little cartoon from my colleague, Dale Sanders. And, thinking about what data you should bring in, it should be around what you need to manage around the patient. What are you trying to answer? In the United States, we really focus on this left lower quadrant, which is healthcare encounter data, which is very important, claims data, biometric data, and even patient-reported outcomes data. But as we continue to grow, we're going to see things like socioeconomic data, more genomics data, which has become even more important. But all these things like wearables, all these things are data that we need to understand. And we have limited data in the healthcare system. Maybe we see someone 3 times a year. Hopefully we aren't seeing people 20 times a year. There are some patients we probably are, but we almost collect no data on healthy patients who really rarely visit the healthcare system. So, thinking about what do we need and what are we going to focus on is important. So as I talked about before, letting the patient be your guide is important. And understanding data to understand how we, the infrastructure on the bottom, our care teams, our infrastructure, our data operating system, our technology tools, our delivery models really should be all geared towards understanding from a data perspective who are healthy, but who are particularly a rising risk, are high-risk patients, and what are the tactics that we're going to think about intervening. If we don't have meaningful tactics, it's really not helpful to identify those patients in risk stratification. This is an example from our analyst about the different requests and the difference between 2017 to 2020 about the difference of what people are asking for when they're talking about value-based care, population health. Data aggregation is important. In 2017, we only looked at clinical and claims data. Today, we look at many data sources. Data management, data integration, benchmarks have become much more important. Understanding gaps of care, clinical transformation, and also highlight scenario modeling, AI and ML, machine learning utility, patient engagement and provider engagement are important. So you can see much more needed to manage your population today than even 4 years ago. Here's an example of power of data integration. One is thinking about understanding the opportunities. So I might be looking at more than one payer source. I might also be looking at state databases, national databases, external quality databases, looking at more than one healthcare record. It might be Epic, Cerner, Meditech. I know that Singapore has 2 primarily. Looking at satisfaction, looking at patient-reported data are important. When I start to look at what my cost is, I start to want to bring in more procedures, labs, pharmacy, Lawson, different financial HR system, workforce, or even supply chain. And when I want to understand how I'm doing on the total risk contract, I might need to bring in planning, budgeting, or forecasting. And importantly, that we have standardized definitions and ability to match the patients and provider roster is important. Another thing I want to talk about is avoiding the trap of population health measurement. Measurement is really important. And as you think about this, many times we say, okay, let's focus on our diabetic patients. And so, we might look at the coding and pull that list and send our case managers out or primary care out to look at those. What is actually needed is looking at patients with poor diabetic control and starting to identify this more specifically. So for instance, this is A1Cs over 9. And not only understanding people that have A1Cs over 9, but understanding their utilization, their medication management, their comorbidities, screening, and education. And even if we look on the left-hand side, high utilization, patient, clinic provider, were they in the ED and patient? And in the end, how do we match the interventions as we saw in the earlier slide is really important. This is the kind of level of data that you'll need to manage these patients. In the last couple minutes, I just want to cover a couple things. One is benchmark comparisons. as you're thinking about value-based care, you'll need two types of benchmarking. One is around our payer, creating target for population's total cost based on historical cost. And so you might want to take, claims for 3 years and look at that and understand weights and all those things. That's very important. From a member or improvement or provider perspective, you're still going to be wanting to understand those claims data, but you're going to want to look at it more frequently, and you're going to need more data than claims to explore your populations, look at your trends, include your access patterns, utilization, social determinants of health. And really, in particular, as we saw in the previous slide, is care teams based on risk and clinical conditions so you can intervene. So there's a lot more detail around the benchmark around being a provider. So how do organizations succeed in population health? I think you have to agile, transparent, and comprehensive analytics to succeed now and the future. Thinking about self-service, how do I provide these to frontline providers? How do we actually understand, how to get there and provide data that helps them manage? Transparency is really important. You providers cannot work on black box calculations. They need to understand what's in there. Understanding how we get good registries is important. Data informed in comprehensive analytics. We've talked about that, bringing the data in, having a single source of truth. AI insights are important. Bringing the right people, the right time, out of box, how to drive the strategy, how to bring integration, looking at the process is important. And finally, what's really important is increasing your outcomes and actually executing on understanding that data. I just wanted to end with a couple success stories. This came from Partners Healthcare, which is now MGB. They've used their data, they've integrated their data to drive, and you can see the improvements on diabetes management and cardiovascular management. They were able to improve their hemoglobin A1C within the recommended guidelines. They actually help people control their hypertension and cholesterol, and you can see very similar in others. So this is just an example, and we have a multitude of stories that you're welcome to go look at on our website. But these are actually areas where good organizations focus on managing the dollars, managing the cost of care, and quality at the same time. So you can see the importance of looking at all of those across there. So I think that is the end of the presentation. I just wanted to share with you that this is a big transformation as you think about moving towards value-based care. You have to think about your data differently. You have to think about your managing chronic conditions differently, and it requires change for the entire family of healthcare providers. And so as you're thinking about how do we provide great data to look at this, think about, what is it that you really need, because there's so much data involved. How do you really target as you bring in and decide how to improve care? So thank you for your time today, and I think we turn it time for questions.
Hey, thank you, Ms. Rimmasch, for the insights to start us off this morning. Actually, as you know, I actually have a couple of questions from the audience. As you know, Singapore, we are embarking on this journey for population health. And I recall in your talk, you mentioned something about different tactics for different patients. So we're just wondering, for the motivated patients, it's relatively easy to engage and empower them digitally. But what about the unmotivated patients and consumers? Just wondering, how do other healthcare systems tackle this segment?
Yeah, that's a fantastic question, and difficult to do because we're all individuals and it relates to behavior. But I would say that, one of the key things that we're seeing in systems that we work with is they're trying to build a more effective partnership with the patient. And part of that we see is using patient engagement tools that are really focused on activating and supporting and reassuring the patient. These tools engage patients on mobile devices, and I've seen it mobile phones, iPads, patient portals, whole bunch of different ways, and they can help empower care teams and reduce care variation by automatically keeping patients on track with their care plan. So it's almost like a GPS for healthcare. They can provide personalized step-by-step instructions based on clinical programs. They can support assessment forms, things like appointment reminders, care plan instructions, educational videos, encouragement, even navigation, directions, prevention and wellness coaching, even remote patient monitoring and device integration, and even pulling up satisfaction surveys. So it's been interesting that, by watching this, that I've actually had increased compliance to care plan, increased compliance to prevention, increased. So there's been some significant things, decreased in readmissions because of compliance. And I think what we're seeing is, the other thing is those tools are, many of them are focusing on personalizing the information to that individual. And even thinking and learning, using machine learning to understand when is best to approach an individual. Like if you work every day, in the middle of the day is probably not good. So that's one of the things. And I think the other thing is we've seen systems that are addressing, trying to create positive incentives. And what we're seeing is, to participate in health improvement activities. So being positive has been more impactful than just saying, telling them every day that you've got to do this.
Thank you. Seems like the audience is quite interested in that triangle or pyramid that you showed about the patient stratification. And some members of the audience are just wondering whether you can share more about the different patient stratification strategies, the pros and cons.
Yeah, I'd be happy to talk about it. We could talk about this for a long time. But I think it is important to have stratification that leads to meaningful interventions. And I would say the one thing that more programs learn is that's the end factor. So don't create more risk stratifications than you actually need. But, I think as you look at that triangle, you look at that, you've got the wellness people that are well. And so the targeted interventions around there are prevention. And then you have a couple different ways you can look at risk stratification that I've seen. One is you're looking at the low, moderate, or high risk, and you're looking at kind of a general risk categorization. So you might be looking at someone that has polypharmacy, high number of readmissions, and maybe is an age over 85 or 65, however you want to look at that. And so it's kind of general interventions. So you're trying to understand how to manage polypharmacy. But the other way to think about risk stratification is really targeted to their maybe clinical condition. So, I know it's not very often that people only have heart failure. They might have heart failure and diabetes, but, stratifying those by heart failure and diabetes are important. So, one thing we know about heart failure is readmission levels are very high for heart failure. So we see many programs actually risk stratifying on those conditions and then bringing in best practices, using these different strategies to do that. So those are kind of the two ways that I've seen managing. And then the last thing I'll say is one of the most important categories in value-based care is managing the rising risk. Those that actually you can prevent or change or slow down the process of getting to high risk. And the last area for intervention there is important is because those individuals, as they're going through having those discussions about palliative care and what they really want to do. Do you want to keep, intensely doing, interventions when they may not want to do that? And that's a really important aspect and a really important part to value-based care.
Thanks, Holly. We probably have time for just one more question.
Okay.
This is related to patients who may not be so digitally savvy. That may be technologically disadvantaged for whatever reason. Although, we have very high mobile phone adoption, but there would still be that segment of population who may not be able to be digitally engaged. So just curious, how do some health systems deal with that?
Yeah. I think even when I gave like the example Concerto Health, I think it's a reality that particularly when you have very high risk or fragile or frail people, sometimes it's very hard for them to use digital. And I think that you have to have both. I think you have to have a strategy for those that really can't seem to use that or can't get that. I mean, what's been interesting that we've seen is that it's amazing how many actually individuals, even high risk today, are able to use digital strategies like the phone. But the other strategy is pick up the phone and call. I think, we kind of forget about that. There's that's been an important strategy of just calling people. So I think you have different mechanisms to do that. But I do think that we are getting better and better to have access, and even low income people we've looked at the data around there. It's very high for them ability to do that. So it is challenging. And, but I do think we have to have a mixed strategy there. You cannot choose one or the other, particularly in the high risk group.
Thank you, Ms. Rimmasch, for all the excellent answers to the questions and for the good insights in your talk this morning. We have come to the close of this session. I would like to also thank the audience for the great questions that were given and participation in this segment. Thank you, everyone.
Thank you. Bye-bye.